Okay, people are moving in. I think we're going to try and get started. We are a little behind time. We want to respect all the presenters. We have a few strategies in mind to catch up as we move through the day. And so with that in mind, I'm going to turn the podium over to Dr. Whitney Jones, who's been a long-term supporter of the Roundtable. And also, it's really important to acknowledge that for many, many, many years, Dr. Jones has been talking to all of us about earlier screening and on-time screening. He really helped to turn on a few light bulbs for quite a few of us. So he's a gentleman who's ahead of his time, and so we thought it was entirely appropriate for him to head up this session on earliest possible stage diagnosis, which, as we've heard many, many times today, is a key issue and a key failing in our current healthcare system. So with that, I'm going to hand everything over to Dr. Jones. Please join me in welcoming him. He's done a fantastic job in this arena, and I know it's going to be an outstanding session.
Thanks, Tom. Hi, guys. Everybody okay after lunch? Waking up a little bit, give your head a shake, need some espresso here. Well, I'm from Kentucky, which is the state that always has the highest rates of cancer, and we lead the nation in early age onset colon cancer. So that's a dubious honor to be here, but I think I can predict that in a few years we will not be in that particular status. So this is a session around earliest stage diagnosis and how we're able to really impact that, and we're going to touch on a bunch of areas. And what I was tasked with to start that was early age colorectal cancer delays in diagnosis and the consequences for late-stage diagnosis and improving outcomes. Here's my financial disclosures, and let's get right in it. Because this is the number that really gets everybody nervous, this graph, that essentially shows that younger people have less localized disease diagnosed at the time of diagnosis and more regional and distant disease, suggesting one of two things, either that delays in diagnosis are responsible or perhaps there's other underlying issues such as tumor biology. And so the question isn't really whether or not delays in diagnosis are good. They are clearly bad. Okay? The real question is what's the overall impact from a larger standpoint? Because I asked Rebecca Siegel, because I'm not as smart as Rebecca Siegel, is this not just what happens when you have a screening program for people over 50? That you're going to find more early stage disease and more advanced stage? Because I can tell you, people who are over 50 who don't get screened, who present with symptoms, have the exact same characteristics that someone who's under 50 has. They tend to delay their going to the doctor. They might have a little more information around colon cancer because our focus has been 50. But a lot of the same issues go on for older people who aren't enrolled in screening in terms of delays. She assured me that this is not all a screening effect, which made me think if this isn't a screening effect, perhaps we need to reevaluate our over 50 screening program, because this should be a screening effect. So I would start off by saying, are we really dealing with apples and oranges? When we talk about sporadic, and I don't get to talk about family history, which is my favorite thing, so I'm going to try not to, but I might mention it. What are the things going on about sporadic colon cancer that are going to change and we can do things about it versus things that we cannot? Well, we're not going to change tumor biology. Tumors are going to be tumors. We can't change that. We can't change that people with sporadic colorectal cancer don't have a family history. We're learning more about adenomas, other ways that we can impact it, but they're not going to have it. And for 2019 at least, we do not have a screening program for sporadic colon cancer under the age of 45. We do over 45, but not for under. So what can we change? Well, we can improve the awareness of symptoms, both of patients and of providers. We can link that awareness with seeking medical help, because being aware of something and knowing you have a problem is different than knowing you're having a problem that could be colon cancer and you have to get checked. So there has to be linkage, and we'll talk a little bit about that sequence. And then finally, on the provider side, we got to learn to reduce delays in diagnosis. So here's a couple of case reports, because I'm just a simple clinician from Kentucky. And I want you to frame this whole discussion around these two patients. A 48-year-old healthy male, painless rectal bleeding times 1 day, no family history of colon cancer or other cancers. He undergoes a diagnostic colonoscopy 2 days after the onset of his symptoms. He has a 2.5 centimeter pedunculated polyp in the sigmoid that has high-grade dysplasia, but it's completely resected. At that time, there's no genetic testing indicated for him, and he had no indications outside of this polyp of any cancer family history. Not too long after that, I saw this second patient, a 24-year-old healthy male who presented with painless rectal bleeding times 1 day, 1 episode, no family history of cancer or colorectal cancer. He also had a diagnostic colonoscopy within 2 days of his symptoms. He also had a 2.5 centimeter pedunculated sigmoid polyp, but he had invasive mucinous adenocarcinoma of the colon that got into the stalk because it was a big broad base. I thought I'd gotten it. His pre-op multi-gene panel testing was normal, and I would certainly encourage pre-operative multi-gene panel testing when you can get that. And at surgery, he had a T3N1 cancer. So if you think this is a perplexing issue, it is a perplexing issue. And would later diagnosis have hurt either of these people? I would argue it would have hurt both of these people. But I don't know how I could have done an earlier diagnostic evaluation because the guy on the right is my brother-in-law, and the guy on the left is one of my partners in awareness prevention messaging in the state of Kentucky. What they did have was extremely high awareness because they knew it was a problem. They called immediately. We got in. So as we move forward, that's going to be a focus. So let me just be an attorney for a second and make an argument. I think we know everything we need to know about sporadic in the definition. It's everyone, not family history, mind you. So what that means is we're going to have to talk to people over 21, everyone, when we educate. That's just the way it is. It's hard to stomach. I would also make the argument that we also understand the presentation of the symptoms, and that's established. Clinical complaints, rectal bleeding, bowel habits, particularly loose stools and bleeding are very, very strong. Unexplained weight loss, fatigue. We have rectal examinations, physical examinations. We have lab results. These are well established. They do not require additional study. Here's 5 studies. 2 of these are from organizations that are working on colon cancer. NCCRT, the Never Too Young and the UK Bowel Organization. Both showed significant delays in symptom presentation. And they suggested that stages 3 and 4 were higher in people who had more prolonged diagnostic delays. And I certainly think that that's true, but this was a reported piece. Studies, however, that have been randomized controlled, this was people over and under 50 with symptom duration, they were not suggestive that the delay in diagnoses was related to a change in stage down the road. Likewise, another one, Biomed Research, talked about missed diagnostic opportunities. They didn't give stage information, but I just love that term because I'm an opportunity-driven guy. Did we miss an opportunity? And then finally, an American Journal of Surgery one where there was no difference at stage in diagnosis, but the key part here was look at the difference in the presentation of these folks. These are young folks under 50 who waited a long time to see the doctor. But once they got into the doctor, they had a relatively similar stage of workup. So I think there's problems on the front side of the doctor's door and on the back side. What we do know that, and this is according to the UK Bowel Cancer Association, awareness does correlate pretty significantly with stage. So those who have higher awareness tend to be diagnosed at earlier stages than those who are late. And I don't think we have established awareness amongst providers or patients in our population. And I think part of it is this reason here, because in this esteemed academic conference, we know a lot about epidemiology of sporadic colon cancer, but we don't know anything yet about the etiology. But somehow that limits us from creating awareness, and not only in specialists, but also in primary care physicians. And I would argue the under 50 population is clueless at this time about these issues. And unfortunately, unless you're aware, you cannot link that to an action such as being screened, preventing early, behavioral changes. So this is, in fact, I believe, our gap. Because this is what it looks like, I think, right now. This is another way of laying out that timeline. When the symptom onset happens, are people aware of it? How long does it take them to be aware of it? How long does it take them to get over the emotional and behavioral issues that go along with being embarrassed about talking about their bowel habits before they actually call the doctor or see their family practitioner? This is also an issue with people who have access issues and disparities amongst their organizations, their groups they're in. But finally, when they get to the doctor's door and they get on the other side, does that frontline provider deal with it? What do men do? They don't have doctors between the time they're 40 and 50. They don't know about it. They're not getting the communication. And so the specialist eventually sees them. So our goal here, really, is to not go from months, but to go to weeks, so it looks more like this. And really what we want to do is develop a singularity of the onset and awareness and make an appointment to shorten the patient part and really educate folks about the signs and symptoms of cancer. And I think how we're going to do that, and my wife said I couldn't use BOGO, which means buy one, get one free, but I'm doing it. Because this is the current message package, right? We give current message package right here. And we give all our money to the 45, 50 now, and I love 45. But the fact of the matter is colon cancer is increasing all the way up to 54. So we have to have a reality check about whether our message timing is working or not, and I would argue it is not. What we need to do instead is consider an alternative way of delivering that message, and message means money, because you got to pay or earn it. And in fact, what I believe we need to do is bring this back into what I would call an early messaging package, where we in fact look at people who have family histories, and I think this is the vector that we need to use because we can all agree on family history is important. At the same time, educate them with information about symptoms and what to do if they have them, and God forbid we tell people not to smoke and not eat bacon and everything else, but we can at least have consensus on that as well. And so what I really am looking to see is in fact a change in the distribution, a reapportionment of funds to fund that message. And the real piece is that the buy one, get one free of messaging people earlier, which means we will be able to get people screened on time at 40 or 35 or 45 and actually alter our entire communication strategy upstream. So what are the conclusions from my standpoint? Delays in diagnosis may and almost certainly in some form contribute to advanced stage diagnosis, but it's not conclusive. Both population and provider awareness are the major contributors to these delays. And I would argue that we already have effective knowledge around and messages for prevention of the earliest stage diagnosis. They already exist, but they're not delivered on time or with adequate frequency, and we have to have awareness, action, resource messaging that's fully integrated, emphasized, and delivered to the over 21 population, proportionate to the anticipated incidence trends. Thank you very much.